Okay, so welcome everyone to our first event of the year by the Wits Students Physician Society. So in honor of World TB Day, we're going to be learning about the disease from one of the best, Professor Keertan Dheda. He is a specialist pulmonologist and professor of respiratory medicine. At UCT, he is the head of the Division of Pulmonology, as well as the director of the Center for Lung Infection and Immunity. He is also a professor of mycobacteriology and global health at the London School of Hygiene and Tropical Medicine. His research areas of interest includes diagnostic tools and intervention for drug-sensitive and drug-resistant TB. He is a global leader in this field, having published over 320 peer-reviewed papers, holds 6 patents related to novel TB control technologies, and manages several multi-centric clinical trials related to TB or COVID diagnosis and transmission. He has also held several advisory or editorial positions, including to the WHO and Lancet Respiratory Medicine, and been involved in the development of several global health programs. So without further ado, Prof Diet is now going to give his talk.
Thank you, Imaan, for that very kind introduction. And it's really a privilege and an honor and a pleasure to talk to you this evening. Well, for those of you who don't know, I actually qualified at Wits. I was part of the 1992 class, and we now have a WhatsApp group going, and we will be having a reunion later this year. So it's really timely and really a great singular pleasure to be able to address you today. The topic that I chose is the intersecting epidemics of COVID-19 and TB. Both these you hear of and have been hearing of in the last few years. And I thought it'd be very interesting to say a little bit about both these pandemics. And the obvious question is, how do they intersect? I'm going to keep the talk fairly short to probably about 20 minutes, and then we'll stop, and then we can have plenty of time for questions and discussion. So can you see my screen? Okay, Imaan?
Yes, Prof, we can see it. Thank you.
Okay, great. So the first part of my talk will really address the issue of the impact of COVID-19 on other respiratory infections, not only TB. And then I'll talk a little bit about the current state of TB and COVID-19 pandemics globally and in South Africa in particular. And then, very importantly, it's all good and well talking about the burden of these diseases, but how can we mitigate or address the effect of COVID-19 on TB? Most of you would have guessed by now that COVID-19 has a negative or deleterious impact on TB case detection and mortality, and that's something that we can talk about. So COVID-19 has impacted a number of respiratory diseases. Firstly, it's because probably related to masking and social distancing, it's resulted in a reduction of seasonal viruses. We've had a substantial reduction in the detection of influenza virus, and also bacterial infections. So let me just get my, right. So not sure what's happening with my slide advance, but hopefully it'll work better now. And we've also seen a reduction in asthma and COPD exacerbations. And this is probably related to the reduced circulation of respiratory pathogens. We've also seen a reduction in the diagnosis of lung cancer, which is the #1 cancer in terms of mortality worldwide. And so, as you can see, COVID-19 has resulted in some way in reductions in the burden of respiratory diseases, either directly due to social distancing or masking, or in the case of lung cancer, due to reduced detection and barriers to accessing healthcare. What about TB? Now, TB is a major problem globally. It's far from eradicated. I'm sure most of you know that. And about 3 people die of tuberculosis every minute. I mean, can you imagine that? It's the most common cause of pulmonary fibrosis. We call that post-TB lung disease. And that's something that you will see in clinical practice. You know, we don't think about it. You treat a urine infection and it's gone. You treat TB, and in about 5 to 10% of cases, you have this chronic damage or lung disability. The other aspect is that we don't often talk about the reduction in GDP, which is about 2 to 3%, because TB affects the economically active young population. And that's actually, in monetary terms, more than our entire health spend, right? So it's a no-brainer. We need to invest more in TB. And I think this is a very important thing that we forget. We actually don't know how much TB costs the country annually, which is also quite strange and bizarre. And hopefully this will be a good research idea for some of you to write about this or to actually work this out. And it's the most common, it's the most common cause of death in South Africa over the last decade. And in fact, in 2020, more people died of TB than of COVID-19 in South Africa. And here's some very well-known and famous personalities who had TB. TB is a heavily stigmatized disease. There are all sorts of fears around TB. And this is also important for you. It's not only the biomedical construct you need to remember, you also need to remember the social construct, right? TB has many social determinants and drivers, including poverty and overcrowding, but there's also a lot of stigma, fear attached to things like TB and HIV and even COVID-19. And it's important to reassure patients when you see them that, in fact, TB doesn't affect fertility or reproduction. Largely, it's not something that will physically disfigure them. It's easily treated with antibiotics. And it's not genetic. It's not something that's inherent in families or something like that. And there's a lot of stigma and fear around getting TB. It's embarrassing. There are lots of implications socially, social shunning, and not actually even getting into relationships or getting married because people have had TB in a particular family. And to some extent, this is prevalent in many different cultures, very strong in countries like on the Indian subcontinent, the latter aspect. So I think this is important to remember. And we remember the words of this well-known physician, William Osler, who said, in the mortality bills, pneumonia is an easily second to TB. Indeed, in many cities, the death rate is now higher, and it has become, to use the phrase of Bunyan, the captain of men of death. So Bunyan was another famous physician in the UK who referred to pneumonia as the captain of the men of death. And William Osler is saying it's that TB eclipses this. And this was in the early 1900s. And he was referring to the period of the late 1800s where TB was the commonest cause of death in the UK, believe it or not. And there were very, very high rates of TB. And we have a similar situation now in many African countries, including South Africa. So TB is not unique to Africa. It's on the rise in the UK. And drug-resistant TB is a major problem in many Eastern European countries and also in Russia. Now, the current status with TB in South Africa is not pretty. What you see on the top in the first or in the upper part of the slide is the estimated TB burden figures for 2020. And I just kept this in because I updated the slide today. And if you look at, let's see if my pointer is working. So if you look at the, can you see my pointer?
Yes, Prof, we can see
it. Good. So if you look at the bottom part of the slide, this was it's 2019 figures. And if you look at the top part, it's the 2020 figures. And there's something strange going on. If you look at the bottom, it's 360 and the top is 328. Now, how can over 1 year, there be such a reduction in TB burden? And that's actually probably related, well, it is related to COVID, and I'll talk a little bit about the impact of COVID on reduced detection of TB. But what you can see from the 2019 figures is that this was the total estimated burden of TB. That means what we estimate, the number of cases we estimate, newly ill patients that were estimated to have become ill in 2019. You can see there's quite a wide confidence here. That's the median, but it could be up to 500,000 cases. And that's quite an astronomical number. The other thing to point out is that you look at the top slide and you see there's quite a big difference in the estimated burden and the notified patients. Can you see that? There's almost 130,000 patient difference, and that's we call that the missing or undetected cases. So I'll talk a little bit more about that, but that's quite startling that about 100 to 150,000 of our TB cases are simply undetected, okay, and undiagnosed, which is, it's quite chilling. And the incidence of TB is very high, roughly about just over 600,000 cases per 100,000 of the population, which is the highest globally for any country with a population of more than 3 million people. So we also have the highest incidence, as you know, of HIV, which is a major driver of TB. And you can look this up online. It was published this morning or late last night. And this is a commentary in the Lancet that came out today, talking about the need to accelerate investment to find these missing patients with TB that I talked about. And here you can see a picture of a mini mobile clinic that we set up, which has portable DNA technology on board. I'll talk a little bit more about that later. And you can see we go out into the peri-urban informal areas where there's a lot of TB. And I'll show you some data on that and how we can actually take diagnostics out into the community. Now, you all know about the global COVID-19 story. And here you can see the various waves in South Africa in the left-hand graphic with another one expected. And on the right-hand bottom, you can see the deaths associated with each wave. And this is quite underestimated because in the green, you can see the total number of deaths that estimates generated by the MRC. And that's something maybe we can deal with in question time. So we know about the reduction in respiratory infections, but what about TB? Will masking and reduced community-based transmission beneficially impact TB burden, right? That's the big question. And the answer is no. So this is another paper, and it's freely available online. It also was published today in a journal called Lancet Respiratory Medicine. And here we discussed in detail the intersecting pandemics of TB and COVID-19, and a lot of what I'm going to say today is really encapsulated in this paper. And if you want, you can just read the abstract and look at the figures and the panels and the tables which tell the whole story. But on the left-hand side, here you can see the actual number of TB tests. Now, the gray line in each case is based on previous years, what the numbers would have looked like in terms of actual tests. And in the red line is what really happened. So you can see in Q1 of 2020, before we had our first wave, those lines were congruent. And after the Q1 2020, you can see the red line departs from what is expected. And so you can see there was a substantial reduction in the by about 40% in the number of tests conducted. And you can see even after that, it doesn't quite catch up. And if you look at the actual number of detected TB cases, you can see this big fallout here. And then you can see another fallout here. and the same for rifampicin-resistant TB. So what we can say is that there's quite a substantial reduction in detection of TB cases if we go by the number of gene expert positive tests. And it turns out that globally, there was a similar picture. You can see in the top panel here, the reduction in TB cases in the different regions of the world, okay? And that translated roughly into an 18% decline overall in the number of people newly diagnosed and reported with TB in 2020. So that's a substantial decline, okay, in detected cases. And here you can see in the bottom panel of the graphs, this is not only see South Africa, I showed you the reduction in the number of cases by the gene expert test that we do. And here you can see on that graphic, but it's not only unique to South Africa. You can look at Indonesia, you look at India, you look at the black line as the baseline, and you can see whether you looked at Brazil, China, India, or Indonesia, compared to the black line, you can see the massive reduction in the number of detected cases. Now, the implications of this, what are the implications of this decreased TB detection on TB mortality? And it's estimated that in 2020, there was an increase in the TB-associated deaths from roughly 1.4 to 1.51 million. And you can see that that's just an estimate. And the reason you may be wondering, like, why is it an estimate? I mean, this was 2020. And the reason is we don't really know, right? All the data hasn't really come in. And actually working out that somebody really died from TB is quite a tricky thing. And maybe we can talk about that later. But essentially, for the first time in more than 20 years, there was actually a global increase in TB mortality. And essentially, this is taking back TB control about 5 to 10 years, closer to 10 years, I would say. And if you look at the graphic for South Africa on the right-hand bottom, you see there the sudden spike in TB mortality after 2020. But the important point is that you can see that the baseline, which is the predicted black line, which is the trajectory we should have been following, you see that it doesn't quite catch up. It's not expected to catch up for a number of years. So we're going to have this raised TB mortality effect for a number of years, and the same in many other countries. And you can see from the top right graphic, for the first time after many, many years, we've had this gradual decline in TB mortality over the last 20 years. And now we've got a reversal. So that's quite chilling and quite alarming. Now, I'm not going to go through this figure in detail at all. It's a figure from this paper that was published today, but it talks about the TB Care Cascade. So it's not only, about detecting TB cases. It's also about access to TB testing. And so you can see in this graphic that here the TB burden is increased by lockdowns and worsening poverty and that kind of thing. But there's also some effect on reducing TB burden because of masking and reduced travel, reduced exposure to TB in taxis. But the net effect of this is a reduction in case detection. And the next thing is, you exposed, but one also then goes to the next level of care, which is access to TB testing. And because of COVID-19, there's been a massive reduction in that because of healthcare workers being ill, laboratories being repurposed, clinics being closed. And then the next level is confirmation of the TB diagnosis. So one is access to testing. Two is actually confirming the diagnosis. Many people don't come back to even get their results. Reduction in treatment initiation and reduction in treatment success because of disruption of clinics and getting drugs to people and so forth. So, we have to think about the TB cascade rather than just reduction in diagnosis. So that's all good and well. What are we going to do about it? And how do we revitalize TB testing and treatment? Now, I think firstly, we need to have increased awareness and accountability. And we've had all these public facing dashboards of COVID-19, right? Every day you put the news on, whichever station you watch in the corner, you'll see a graphic. It's on the internet. We have these dashboards that change second by second and minute by minute. And that's brought a lot of accountability and awareness about COVID-19. And we don't have that for TB, which is very strange because, you know, it's an epidemic or a pandemic that's been going on for decades. It's been the #1 killer in the country for the last decade or more, and yet we don't have that. But I'm happy to say that situation has changed. There is a TB dashboard now in the Western Cape, and I'm hoping that, you know, there'll be a national dashboard. And next to COVID, we'll see this dashboard clicking away every day, which will bring much greater awareness to TB, and hopefully will convince politicians, policymakers, and people to contribute and invest in TB research and development. And we made the point in our Lancet commentary today that we as Africans need to invest a lot more at every level. We, at individual level, giving to TB charities and increasing advocacy for TB, and our own government investing a lot more into TB research and development, because it's only through research and development that we're going to accelerate the development of new tests, new diagnostics, new treatment strategies, new vaccines, right? It is quite extraordinary, and we make this point in the commentary. If you want to read that, it's quite interesting, that in under 2 years, literally 18 months, right, from scratch, we developed new diagnostics, we developed new drugs. There's molnupiravir, and there's Paxlovid from Pfizer, which is active drugs against COVID-19 that work. There's also remdesivir. And not only that, we not only developed a vaccine, but we rolled it out to hundreds of millions of people, all in under 2 years. I mean, can you believe it? Now, you know, there are challenges with TB, but it's quite telling that we spent so far roughly over, I think the number is over $100 billion on COVID vaccine development. And we spend less than 1/100th, or I think it's even less than that, 1,000th on TB vaccine development, even in the last decade. I mean, that is just insane, right? And it's also quite telling that we had one candidate, TB vaccine candidate, that looked quite good, well, modestly good, vaccine efficacy of only 50%. And that phase 2B trial was done 8 years ago. So for the last 8 years, we haven't started a phase 3 trial with this vaccine that, you know, looks like our best bet in massively reducing the global TB burden. And that is quite telling. And the question is why? And maybe that's something that we can talk about later on. The other thing that I wanted to mention is screening tools. We learned from COVID that WhatsApp screening tools work very well. And I'm glad to say that we do have a screening tool for TB now. It's available. I don't know, it'd be interesting to hear from you whether you've heard of this. I've got this app on my phone. It works by WhatsApp, and it simply asks you to answer about 5 questions and then directs you to go for a TB test. And I don't know how well circulated this app is in the general population, but what I can tell you, in the first 20,000 screenings, the positivity rate of those who tested, in other words, if you answered the app and you had some symptom, you were directed to go to test. And of those that tested, there was a 12.8% positivity rate. I mean, that is incredible. Can you believe it? All right, so moving on from there, I wanted to tell you about the National TB Survey. I don't know how many of you are aware, in 2018-19, there was a South African National TB Survey. It was a door-to-door survey. They randomly covered a whole bunch of regions throughout South Africa. But the rub is that 58% of all confirmed cases In other words, culture positive cases had no symptoms. So there's something wrong with our whole public health strategy, right? And this is not only in South Africa, but globally. Firstly, we're missing a third of the cases, right? They are walking around in our communities. So, we are practicing a public health strategy called passive case finding. This relies on the patient self-reporting to a clinic or a hospital. But we're never going to get on top of TB because there's this whole reservoir of people that is undetected. They're in our communities and they are sentinels for TB transmission. So we have to take diagnosis out into the community. So that's the one thing. But the other thing is that of the people that have TB in our country, most don't have symptoms. So this strategy of relying on people to come to our healthcare facilities is fundamentally flawed. Why would they come? They don't have any symptoms or they don't perceive they have any symptoms. So we got to go out and actively look for them. And therefore, I would say to you, as a big take-home message from this talk, have a very low index for testing with TB. Not only high-risk groups, right, but everyone. What are high-risk groups? Prisoners, contacts of TB people, alcohol abuse, obviously, diabetics, HIV-infected people. But it's actually almost everyone, right? Because if you go into the peri-urban informal settlements in Johannesburg, 1 in 100 people is walking around with TB. So it's basically everyone. I don't think one needs to, it's a no-brainer. You don't have to think about that. Now, this is a slide that I actually started generating about 10 years ago, I think. Actually, more than 10 years ago. And you can see I've retained this graphic on the left, which is actually reporting numbers from 2012. This was a 2013 global TB report. And even then, there were 3 million missed or undetected TB cases. And in 2019, that number, look, was still 3 million. In fact, it's chilling. And it's stunning that in 2020, that number went to 4 million. Can you believe it? 4 million out of the 10 million newly ill people in 2020 globally remained undetected or undiagnosed. And in South Africa, as I told you, that amounts to somewhere between 150 to 200,000 people with TB. I mean, it's just insane. And this graphic on the right, as you can see, this graphic shows you what's happening with TB. These are the taps open. These are people largely undetected in the community that are transmitting TB. And here we are trying to control TB by mopping the floor. We're not really closing the taps. And if we want to close the taps, we really need to go out into the communities and find TB. And we call that active case finding. Now, we've spent the last sort of 5 to 10 years developing a active case finding model for TB. And this slide tells the whole story. On the left, here you see we published this paper in 2017. And what we did from about 2014, we thought, well, we've got GeneXpert, why don't we just put it on a mini truck? We had a generator, and let's go out into our communities and see how much of TB we can find. We found a lot of TB, prevalence of 10% of those that we actively tested who had any symptom that we screened. So we thought, well, this is not really scalable. I mean, can you really invest or scale up these mini trucks? They're quite expensive, have generators and all this type of thing. It's quite unwieldy. So we packed all this into a, it's not actually an SUV. The technical term is a minivan. It's like a Toyota Avanza type of car. This is in the back of in this case, it was a Nissan, but any one of them will do. And we developed a model. You can see the Expert Edge, it's battery operated Expert. You put its back, and everything is in this back of one vehicle. And we went out into TB hotspots. We went out into Langa, and we also did this, in fact, in Zimbabwe. And essentially this is, we actually have been distracted by COVID, and we need to actually submit this and get it published. But here's a study we finished about a year ago, where we screened over 5,000 people in peri-urban informal settlements. This was in 2 areas of Cape Town. And here you can see pictures here of the setup. And anyway, I'm not going to go through the slide in detail. Of the people who came to this mini mobile clinic in the informal settlements and areas where there were a high level of informal housing, we sort of parked this little mobile clinic, outside community centers and thoroughfares where people went to shop and where they had to walk through. And people spent less than 10 minutes. They answered 5 questions. If they had any symptom, then we performed targeted screening. We tested them. And the bottom line is that this was a randomized controlled trial, and we either did gene expert, portable gene expert, or we did smear microscopy, which is the conventional test. It's the only point of care test available to many countries. That's why we chose that as the comparator. And bottom line is that expert performed much better, obviously, than smear microscopy, much higher proportion initiating treatment. Nevertheless, expert only picks up roughly about 50% of the TB out there, right? So, which is another problem. We need better TB tests. And you could leverage this strategy even for other diseases. I mean, in fact, we screened for HIV as well, and we picked up 7.9% of people that were actually got targeted screening turned out to have new HIV diagnoses, right? So there's a lot of people also walking around with undiagnosed HIV. You could do the same for diabetes screening or whatever. So you could use this model for lots of different things. Now, you may say, well, that's all good and well, but you only pick up half the TB burden or just over half the TB burden. And what's really important is, are you picking up the infectious patients? Because they're the ones that are really, transmitting disease. I mean, no stigma attached to the patients themselves, obviously. It's not their fault that they have TB. So what we did is we use cough aerosol sampling. And what this is people cough into a device like this. Patients are transported to a special facility. This is called a cascade impactor. And what this really has is filters in a cartridge. And here you can see one of the plates, and this is actually growth of TB bugs. Each little spot here is actually growth of a colony of TB bacilli emanating from a single particle less than 5 microns in diameter. So these are respirable particles. These are particles that penetrate deep into the lung, into the alveoli. And we published this in Nature Medicine. And in fact, this cough aerosol sampling has been shown to be a very well-validated measure of infectiousness if you're looking at human outcomes in TB. And the bottom line is, Gene Expert, when you just picked up the Cas positive or the infectious patients, Gene Expert detected almost all of them. So you may say, well, look, you only pick up, Expert only picks up this portable Expert, which we deploy in the community, only picks up half the culture positive people. Yes, that's true, but it picks up almost everyone that in fact is likely infectious. Now we have 2 randomized controlled trials that are ongoing now to develop this model further. One is looking at, do you really need the portable Expert in the mobile clinic, or can you just collect the sample and send it to the lab? Will people come back for their results? And the second trial is looking at X-rays as a screening test, portable X-rays that can direct whether you do the portable Expert or not. These are being done across 3 African countries and involve tens of thousands of patients with TB. And these trials are funded by the Wellcome Trust, the UK MRC, and the European Union. And in fact, The Exact3 has already started in 3 countries. Exact19 has just been launched in South Africa. So these are massive, large-scale intervention trials that will develop this model further. And at the moment, the model is available to use. And it's something that we're trying to deploy. We've got it deployed in Cape Town, and we're trying to now deploy it in other cities in South Africa. And this just shows you the similar picture and the Exact3 study and the Exact19 study. I'm not going to go through the structures of these randomized controlled trials. So the key learning points are that due to COVID, TB testing and case detection has dropped by 35 to 50%, with an increase in TB mortality and excess long-term TB mortality expected over the next few years, which is quite depressing. And one should have a very low index, therefore, of testing for TB in any situation, but particularly when you're testing for COVID, because the symptoms of TB and COVID are indistinguishable. And people talk about, cough for 2 weeks and cough for 3 weeks and cough for 6 weeks. I would say any cough. I just showed you the data. 60% of TB, right, had no symptoms, or people perceived they didn't have any symptoms. So what's the point of asking about, fractionating cough and things like that? And I didn't show you the data here, but acute TB, also called TB pneumonia, we taught that when you have a lower respiratory tract infection, it's symptoms for less than 2 weeks. And then you got to think of bacterial and viral pathogens. But however, I didn't show you the data, but I can tell you now that's not true. That teaching needs to change, because it's not true. In fact, if you look at many recent studies, not only from South Africa, but elsewhere, if you look at acute lower respiratory tract infection, there was a big study from Peter Maritzburg, from Cheryl Cohen's and colleagues, and they showed that the commonest pathogen in acute lower respiratory tract infection wasn't pneumococcus, right? We think it's pneumococcal pneumonia. It wasn't, it was actually TB. So TB also presents as an acute pneumonia. And, this is something that we need to change our teaching on this. And this is another big message for you today. So you should have a very low index of testing for TB, even if people are presenting with an acute lower respiratory tract infection. You'd say, oh, well, this person's only got symptoms for under 2 weeks, and we're going to test for COVID, not going to test for TB. And TB and COVID can co-present. In fact, about 5 to 10% of cases have both TB and COVID-19. One would expect that there's so many people walking around with undiagnosed TB, then they get COVID, they present to a healthcare facility. It's not rocket science that you're going to pick up TB and COVID-19. And the last learning point is we have to change our thinking. We have to change our public health strategy. We need to take diagnostics out of our clinics and our healthcare facilities and go out into the community. And this is just one aspect of TB control. But if we don't do that, we're not going to control TB. Of course, in parallel, we need to address HIV. We need to address poverty and overcrowding. Number one driver of TB, cigarette smoking, huge driver of TB in the country, and also indoor and outdoor air pollution. A lot of people in our peri-urban settlements are still using coal and wood for cooking, and that, these pollutants disarm the leukocyte or macrophage or protective immune responses in the alveoli. And that also is a major driver of TB. In fact, cigarette smoking globally is a bigger driver of TB than HIV. Go and look it up. And I think I will stop there. And this is to acknowledge a whole bunch of people. I'm not going to go through names, from the NICD, the Department of Health, TB, various charities, funders, and I put some of the pictures up of people. And, obviously I present this work on behalf of a whole bunch of people. And there's the research group that I head up, the Center for Lung Infection and Immunity, which is embedded within the Division of Pulmonology. And I hope this will inspire you to change your view on TB and will inspire you in whatever way to improve advocacy for TB, to care better for patients with TB. And hopefully some of you will actually embark on research careers or perform some kind of research that will facilitate our efforts in holding hands together to fight TB. So I think I'll stop there, and let's rather take any questions and discussion. So I'll hand back to the chair. Thank you.
Thank you so much for that very interesting and informative talk, Prof Dheda. I'm not sure if anyone wants to unmute and ask questions. If so, they can do that, but I also have a list of some questions that were sent in. So
Okay,
I'm just
go for it, yeah.
Leave some time first if anyone wants to unmute, but then if not, I'll read out the questions to you.
And also, I think people can post any comments or questions on the chat group. Feel free to do that as well.
Yeah, they can also post it in the chat. Okay, so no one's unmuted, so I'm just going to read you some of the questions that were sent in.
Let's take them one at a time.
Okay, yeah. So the one question was, do you believe that issues arising from the COVID-19 lockdowns may have had negative effects on the TB pandemic in South Africa, such as overcrowding in shacks due to extreme and prolonged curfew regulations?
I think I've answered that question graphically in my slides.
In the talk.
Yeah, so I think the answer is yes, and I showed you the data, how it's reduced TB detection and its deleterious impact on TB mortality. So I think we've slam dunked that one. Okay, next question.
The next question was, are people with conditions such as post-TB bronchiectasis more at risk of serious COVID infections or long-term problems after having COVID?
Yeah, that's a great question. The answer is probably yes. And, there's no data I can show you specifically on post-TB bronchiectasis or a population with post-TB lung disease and COVID. I'm sure that data will come out, but we do know that individuals with post-TB lung disease are more susceptible to various types of infections, including pneumonia, exacerbations of bronchiectasis. And there's very little work, that's been done in this area, which again speaks to this whole TB neglect issue. I mean, post-TB bronchiectasis is so common, but we don't have a very good idea about the microbiology of post-TB bronchiectasis into what organisms are associated with all these exacerbations, etc. There's just hardly any work that's been done. But based on general principles, intuitively, I think the answer is yes. If you have significant post-TB lung disease and TB bronchiectasis, you would be more susceptible to infections, and that probably would extend to COVID-19, and it would be a great research project for one of you to take up. Thanks.
Okay, perfect. Another question was, how has the COVID vaccination affected people who have been living with TB?
So I don't think that COVID vaccinations would have, impacted negatively people who previously had TB. If anything, it would be positive. I showed you that, we know that I just mentioned now that people who've had previous TB, about 5% of them would have significant lung damage. And those individuals are probably more susceptible to COVID-19. And so all the more reason to vaccinate them. So, we should encourage vaccination in everyone, whether they've had previous TB or not. I think that's the key thing. And as you know, that we've got to go back to what is the purpose of vaccination. The purpose of vaccination is to prevent death, firstly, and to prevent hospitalization. Because if you enter hospital, remember, if you had prior to the Omicron, if you entered hospital with COVID-19, for example, in the Delta wave, there was a 1 in 4 chance or 1 in 5 chance you never came out of hospital. So you don't want to get people into hospital. You also enter hospital, there are a lot of complications, a lot of transmission of all sorts of things in hospitals. Hospitals are not good places to be. So we want to prevent death and keep people out of hospital. And there are a whole bunch of reasons why, we don't want burdens on the healthcare system and costs and all sorts of things. So that's really the aim of vaccination, is to prevent death and to keep people out of hospitals. We know that the vaccines don't stop you from getting COVID. We saw that with Omicron. Even if you're vaccinated, you can still get COVID, though it does provide some level of protection against getting COVID. And also, if you get COVID, even though you're vaccinated, you can transmit COVID, though your chances of transmission are reduced somewhat. So, this speaks to the whole vaccine hesitancy group where they say, oh, well, I know so many people who've been vaccinated and they got COVID. Yeah, sure, they did get COVID. They probably transmitted it as well, but substantial reductions in hospitalization and death rates. So that's why we vaccinate. And the same is going to hold true for people who previously had TB. In fact, the benefit in that group is probably likely to be even greater. But if you're asking me for a study showing that people with previous TB actually protected against COVID, we don't have that data. But again, great questions, because already we've got 2 or 3 fantastic research ideas, not for the sake of doing research, but for the sake of answering important questions that are clinically relevant and will impact, policy and practice. Thanks.
Perfect. Thanks, Prof. And then there was a question in the chat from Robin. She said, good evening, Professor. If you are immunized or vaccinated against TB, can you still be a carrier of TB and infect those who are not vaccinated?
So just repeat the question. I didn't quite catch that.
She said, if you are immunized or vaccinated against TB, can you still be a carrier of TB and infect those who are not vaccinated?
Okay, so that's a good question. So firstly, there's a number of messages in that question. The first is that there is no effective vaccine for TB. The vaccine we're currently using is BCG. It's given at birth. It protects against certain serious and disseminated forms of TB in children, like disseminated TB and TB meningitis. But the effect of that vaccine wanes very quickly. It's not effective in adults or partially effective. And overall, after synthesizing many information from tons of studies, the overall protection in adults of BCG is about 30%. So yes, there is a vaccine. It's called BCG. Does it work? Yes. Is it very efficacious? No. What's its protection factor? Roughly about 30%. So some effect, but not great. And we can talk about BCG vaccination for a long time. Sort of intriguing thing. Seems to be more effective, as you go away from the equator, et cetera, et cetera. But the first thing is we don't have a very effective vaccine against TB. And we need to develop one. I mentioned earlier on that almost 8 years ago, we had the data emerge that there was a vaccine that was 50% protective when given to individuals who are BCG vaccinated. And that was done, the patients were recruited from many countries, including South Africa. So that in young adults gave a protection factor of about 50%. Still, great that means if you had a background, if you're BCG vaccinated at birth and you took this vaccine, it was called the M72 vaccine, you were 50% protected against acquiring active TB. And even if we rolled out that vaccine, that would make a huge impact on TB burden. Sadly, since then, a phase 3 trial has not been done. Yet in under 2 years, look how many phase 3 COVID-19 vaccine trials we did. So we need an effective vaccine against TB. We don't have one yet. And there are so many scientific and biomedical reasons why we don't have an effective vaccine. It's an intriguing bug. We don't have correlates of protective immunity, et cetera, et cetera, et cetera. But the bottom line is we've invested very little, relatively speaking, in developing a TB vaccine. In fact, the investment in TB vaccine development in the last decade is 1,000th of what we invested in developing COVID-19 vaccine. And a lot of people have asked, what has that got to do with this being a poor man's disease or poor person's disease rather than COVID-19, which impacts countries other than low and middle income countries. It also raises the question, shouldn't low and middle income countries like South Africa be investing a lot more in TB vaccine development? If we're not going to invest, who is? And it affects our GDPs quite substantially. Causes over the last decade has been the sustained most common cause of death in the country, even surpassing road traffic accidents and violent causes of death. So should we not be investing a hell of a lot more in TB vaccine development? And the obvious answer is yes. And there doesn't seem to be a great appreciation of the fact that it's a no-brainer, something that's reducing your GDP by more than your entire health spend. Obviously, you need to invest in that. Economically, it's going to be very beneficial. And that goes back to the issue of how much is TB costing the country? We don't really know. So these are all question marks, but clearly we really need to wake up. And countries in Africa, in the Indian subcontinent, China, they need to invest a lot more. And hopefully we can leverage gains from COVID, including all the mRNA technologies, the infrastructure that's being developed now. May have heard about all these initiatives already started in South Africa, where there's vaccine manufacturing plants and technology transfer. And we need to capitalize on all that, and hopefully all that will happen. So that's a very long answer to a question, but it was a very big question. Thanks.
Perfect. Prof, it's almost 8, so I wanted to know if you have time for one more question.
Sure, go ahead.
Okay, so Andonia asked in the chat, is there any research or attempt to use mRNA technology to create a TB vaccine?
It's a great question. The answer is yes. There's a thing called a TB vaccine pipeline. And that pipeline is divided into phase 1, phase 2, and phase 3 studies. Now, phase 1 studies, so phase 1 studies are safety trials in humans, and vaccines only get to phase 1 if there's good animal data and efficacy in animal models. And then if they're not safe if they're safe in safety trials, they go to phase 2. Phase 2 means they're bigger studies with more safety data, but they also look at efficacy. There's some efficacy endpoints. And then finally, if it's promising in phase 2, then it goes to phase 3, which are large control trials to confirm the early efficacy signals seen in a phase 2 trial, and it's the more definitive trial that leads to changes in policy and practice. And so, of every 100 vaccine candidates that are developed and enter animal studies, you're lucky if even one makes it to a phase 3 study. So in the last 2-3 decades, we've only had one that's made it to a phase 2B study that showed 50% efficacy. And now we're still waiting 8 years for the phase 3 to start. But to answer your question, yes, there are mRNA TB vaccine candidates that have made it through into phase 1. But I think there are a lot more now that will be coming through. In fact, we're in discussions with some stakeholders to actually try and move some of these studies forward, as are many groups and researchers in South Africa and throughout the world. Thank you.
Perfect. Thank you, Prof. There is one more question, but if you don't have time, then it's okay.
No, okay, we've got 2 more minutes. Let's go for it.
All right. Okay, so someone asked, would a COVID-19 survivor have an increased risk of TB infection or extrapulmonary TB?
Okay, that's a great question. And like everything in medicine, the answer is it depends. Depends on a lot of things. Firstly, it depends on the pre-morbid status. In other words, what was the position before they got COVID-19? So, if somebody had damaged lungs already and comorbidities, that would factor into it. The next thing is how severe was COVID-19? If it was a mild illness, mainly upper respiratory tract, probably likely to have minimal impact. Was it, causing a pneumonia? Was there, and even in people who had COVID-19 pneumonia, most recover substantially, but there's a proportion, 10 or 20%, that actually have substantial residual lung damage. So it depends on that as well. It also depends on the exposure. What was the burden of exposure of TB, and how long was the exposure for? If any exposed for a very short time, low level exposure versus being in a taxi or a room with someone for a protracted period of time. And also it depends on the immunity of somebody. What is their age? Are they immunocompromised? What are are they smokers, non-smokers? And also, what about the person transmitting TB, right? So amongst people with TB, there's a whole spectrum of people. Some are super spreaders. They emit very high volumes of organisms that are culturable compared to other people, and that's a very complex issue. So it depends on a whole range of things. So the answer is yes. If you had COVID-19 before, sure, you might be more susceptible to TB, but it would depend on all those factors. So one would have to look at the individual case. And those would be, though, the key determinants that you'd factor into the equation, to fractionate in an individual case about whether there's increased or no increased risk. Okay, so thanks.
Perfect. Thank you so much, Prof. We really, really appreciate you taking out the time in your day to speak to us about such an interesting and informative topic. And I think everyone has probably learned a lot, and we really appreciate it. So thank you so much.
Thank you, Imaan, and also to Marcel and others in your physician society. It's really inspiring to see this society thrive. I think you guys are doing a wonderful job and really bringing so much of advocacy to so many diseases. And it was a singular pleasure to have addressed you and to have visited the Wits Medical School earlier this year, and to have been in contact with all my colleagues. And I'm looking forward to the reunion this year. And I wish all of you all the best, and really feel free to contact me if you need to, or if you're coming to Cape Town, you can easily arrange a visit down here if any of you are in town. Okay.
Thank you so much again, Prof. Thank you.
Okay, well, have a wonderful evening. Bye-bye.
You too. Goodbye.